surgery indications in acromegaly. Endo Society recommends transsphenoidal surgery as the primary therapy in most patients. Endo Society suggests that repeat surgery be considered in a patient with the residual intercellular disease following initial surgery. Preoperative medical therapy. Endo Society suggests against the routine use of preoperative medical therapy to improve biochemical control after surgery. For patients with severe pharyngeal thickness and sleep apnea, or high output heart failure, we suggest medical therapy with somatostatin receptor ligands, SRLs, preoperatively to reduce surgical risk from severe comorbidities. Postoperative testing. Following surgery, ES suggests measuring an IGF-1 level and a random GH at 12 weeks or later. We also suggest measuring a nadir GH level after a glucose load in a patient with a GH greater than 1 mg per liter. ES recommends performing an imaging study at least 12 weeks after surgery to visualize the residual tumor and adjacent structures. ES suggests MRI as the imaging modality of choice, followed by a CT scan when MRI is contraindicated or unavailable. Medical therapy. ES recommends medical therapy in a patient with a persistent disease following surgery. In a patient with significant disease, i.e., with moderate to severe signs and symptoms of GH excess and without local mass effects, ES suggests use of either SRL or pegvisament as the initial adjuvant medical therapy. In a patient with only modest elevations of serum IGF-1 and mild signs and symptoms of GH excess, ES suggests a trial of a dopamine agonist, usually cabergoline, as the initial adjuvant medical therapy. ES suggests against routine abdominal ultrasound to monitor for gallstone disease in a patient receiving an SRL. Ultrasound should be performed if the patient has signs and symptoms of gallstone disease. ES suggests serial imaging with an MRI scan to evaluate tumor size in a patient receiving pegvisament. ES suggests serial imaging with MRI scan to evaluate tumor size in a patient receiving pegvisament. ES suggests monitoring liver function tests monthly for the first 6 months and then every 6 months in a patient receiving pegvisament, with consideration of discontinuation of pegvisament if the transaminases are greater than 3-fold elevated. ES suggests addition of pegvisament or cabergoline in a patient with inadequate response to an SRL. ES suggests use of an SRL as primary therapy in a patient who cannot be cured by surgery, has extensive cavernous sinus invasion, does not have chiasmal compression, or is a poor surgical candidate.